I am going to start recording here, so hopefully everybody is ready. And here we go. So we're going to start talking about Blur Part 2. And I kind of set this up to kind of establish just a few other things that can cause some blur and whatnot in people's vision before we really tackle the retina here. So let's go ahead and without further ado, here we go. So we're going to talk about movement because obviously the eyes have to move together because if they're not moving in the same direction, you're going to get double vision. We don't want diplopia. So really quick, we talked about before. This is a little bit of review here, which again is not a bad thing since we have a little exercise coming up next week. But we have strabismus. This is a muscular imbalance between the eyes. What that means is the two eyes are not pointed in the same direction. There is unequal fixation. All of that means the exact same thing. And then, as I alluded to, you have diplopia, which, as we talked about, meaning double vision. So the eyes are simply an extension of the brain. The retina literally is brain tissue. And so, therefore, there has to be mental retraining, and the brain must be readapted with therapy if the eyes are not pointing in the same direction. Because again, the brain does not like to be confused. It's just one of those things. We just don't like to make it confused. Oops, but that's too far. But basically, just so you guys know, the acuity or what a person's quality of vision is definitely reduced as a newborn. But between the ages of 6 months and a year, that infant has 20/20 acuity, or in theory, has the ability to get it as long as everything else is developing normally. And this is why they do recommend their first eye exam at 9 months old. So there's that. And yeah, did I do it? Nope. So I didn't heed my own advice, but they do recommend the first eye exam between 9 months and a year old just to check on that development. So different forms of strabismus, and again, heterotropia, this means the constant misalignment of the eyes. So basically, there's different forms of how the eyes may be misaligned. We have an esotropia, which means one eye is pointed inward. We have an exotropia, which means one eye is pointed outwards. And then you have a hypo or hypertropia. Hypo meaning one eye is pointed down, hyper, the other eye is pointed up. Again, you may ask, now what happens if both eyes are pointed down? It's not both hypotropia, it's just you're looking down at that point. Because one eye is always going to be a little bit above or a little bit below the other. Now, where we talk or how this all fits into this whole blur is called amblyopia. And basically, you have reduced vision in one eye. The eye is normally healthy. There is no problems with it. There is no reason that it can't see 20/20 except for the brain is ignoring it. So basically, this happens at the age of under the age of 7 is where amblyopia develops. And basically, there is reduced visual input that allows the brain to actually rewire to focus just on the good eye. Because it's either receiving a blurred image from the other eye or it's receiving double vision. So it picks one eye that it's going to focus on, and that becomes the person's dominant eye. Now, there is no hyperacuity. Just because you're ignoring one eye doesn't mean this other eye becomes like supersonic or supersonic's not, but like this just superhero ability to see even better, like X-ray vision or something like that. It doesn't happen. So there literally is a ceiling to how good a person's vision can be. And that's simply because there is an anatomical limit of how good we can see. And that's literally due to how the photoreceptors are placed in the back of the eye. So we'll talk about that a little bit later, but literally there is a limit to how the best possible vision a person can see. And that's literally because of how the photoreceptors are aligned on the retina. Now, a person can have nystagmus. Nystagmus is a fast, uncontrollable movement of the eye. This is involuntary. So there's an abnormal functioning area of the brain that loses total ocular muscle control. So the eyes are constantly shaking. A person doesn't have the ability to control how the eyes are focusing. It can't make them look just at one spot. So therefore, they might be doing a pendulum, or we call a pendular nystagmus, which is a kind of a rocking back and forth, just like a pendulum on a grandfather clock or something. Jennifer is asking, is this similar to BPPV? And I will be honest, I am not drawing. I'm drawing a blank on what that acronym might be. Vertigo. Okay. Vertigo can definitely have a type of nystagmus. Vertigo being, kind of the having that dizziness where your equilibrium is off and things to that nature. So yes, you can have nystagmus with vertigo. Generally, this type of nystagmus is permanent, where if you have vertigo, it may not be permanent. So it's, but good question. If you see jerk nystagmus, this is not a put down. It just means that the eyes go really fast to one side, so they're more of a jerky motion in their movement. So that is our different forms of nystagmus. The two types that we're going to talk about here, we have congenital. There is literally just a lack of visual stimulation. So the brain never has a clear image. So therefore, in the eye's search of trying to find a clear image, they're constantly moving, and therefore they never stop constantly moving because they've never been able to find a clear image to look at. Now, if you develop this as an adult, this could be because of optic nerve damage or disease. There might be a head injury, such as from trauma, a motor vehicle accident, riding a motorcycle and not wearing a helmet, riding a bike, not wearing a helmet, things to that nature. There could be inner ear disorders. So therefore, hence vertigo normally comes from that. But this is like labyrinthitis or Meniere's disease. A stroke can cause that. And then vitamin B12 deficiency or thiamine deficiency all can cause nystagmus. So Cindy put, there's a question about diabetes can cause it. Diabetes, not necessarily. Now, diabetes is interesting because the increased blood sugar, and we'll talk about diabetes here in the next few slides, but the diabetes with the extra blood sugar in the blood can actually make one of your extraocular muscles become paralyzed. So therefore, that muscle no longer works, and that can cause double vision. So generally, you're going to get double vision and not exactly a nystagmus unless you have severe vision loss with diabetes. Hopefully that helps. And yes, you're right, Alex, that one of the biggest tells of having low vision is because you tend to have nystagmus. So yeah, you're absolutely correct. Now, in infantile nystagmus syndrome, it is very much usually mild, and you can be unaware of the nystagmus, and it's unrelated to any disorder. And the unique part about infantile nystagmus syndrome is there is the potential for 20/20 vision. So you can have perfect vision, but there is a slight movement to the eyes where it's still a mild nystagmus, and that we'd call infantile nystagmus syndrome. And that can, the person may not even be aware of it, but if you go to an eye exam, you can tell. I was pretty proud of myself in optometry school. One of the employees at one of the ophthalmology practices I worked at, I found this for the doc, and that was really cool because they couldn't figure out why. Maybe the balance was off, and I'm like, I really feel this was it, and the doctor verified it. So that was really cool. And this person was 10 years old when this happened, so that was also really cool. So really quick, we're going to talk about lasers and, toss back to was this the 2000s, 90s, I think it was, with talking about lasers with the quotes and everything. So anyway, we're going to talk about lasers. So, alrighty. So laser is literally an acronym. It is light amplification by stimulated emission of radiation. Well, what the heck does that mean? So it's basically a very intense light that is one wavelength. So we know that there's going to be some medium that has to be produced that's going to create this wavelength that is extremely strong and very focused. So it's extremely intense, just one wavelength, and we'll talk about wavelengths more in optics, but it's just one wavelength and it's very, very strong. And basically they use this really strong, intense light to target a tissue to have some type of biological consequences. So there's very much selective damage. Now, the longer the wavelengths, they tend to penetrate and go further back in the eyes. So red, for example, absorbs blue-green. So a blue-green laser is used to hit the retina to basically stop extra bleeding that happens or potentially help heal a retinal detachment, things like that. So there are literally reasons different type of lasers are out there. So the basic mechanisms of lasers, and we only talk about this because your clients may indeed actually have this. So in a thermal laser, heat is actually absorbed by the tissue. So you get this photocoagulation or a nuclear bomb, basically, of that tissue. Like you are literally destroying it. You are just nuking it, for lack of a better term. So we do use this to treat diabetic retinopathy, if there's a vein occlusion within the eye, if there's a retinal hole or a retinal detachment. All of this, we try to destroy tissue in order to stop further bad things happening. How I'm trying to, keep this as simple, and I feel like that's, bad things happening. That's pretty simple to understand, right? So thermal lasers help stop bad things from happening. There we go. Okay, so the basic other mechanisms, we have a photodisruptive. You get a micro explosion of tissue. These can be, so it's basically the power is released over a very extremely short period of time. So these basically are like those secondary membranes or after cataract surgery, we talked about that film that kind of grows over the back of the lens. This helps clean that up. And then also iridotomy. So you place a selective hole through the iris because something's blocking the tissue or you're at fear of the angle itself closing. And therefore, we pop a hole in the iris to make sure that the fluid can still go back and forth. Photochemical is really not used. There are some thoughts about, use it more for cancer, not in the eyes. So that's all we'll say about that. And then photorefractive. Photorefractive is surgical modification of the corneal refractive power. And again, as we've talked about, 2/3 of the power of the bending of light comes from the cornea. So therefore, this is something that, if you want to not wear glasses, you got to have a photorefractive surgery to actually get this taken care of. Alex asks, so I guess the iris can heal itself eventually. Honestly, no. Once there is damage to the iris, it is damaged pretty much for good. You'll see a lot of irises that can be damaged if the cataract surgeon is not paying attention and kind of nicks the iris, but they also pop this hole in there because it's very small. It's off to the side because otherwise, I just saw a patient that, again, they did this iridotomy. They put these two holes in the iris so that way, the doctor thought she'd be at risk for that angle closing. So they did this to stop it. Well, they made those holes too big. So now she's got 3 pupils instead of just 1. So that was stupid. And now the patient has to deal with these pillars of light coming through all the time. I mean, I guess, if you're religious, that's really cool. Like all of a sudden you're like walking in through, God's glory every day, I guess. Again, I'm trying to put a positive spin on it, but it really, really stinks. Christy, you got a question?
New message received.
Yes,
You're
I
muted.
do.
Matthew Johnson.
First off,
Menu
there
on.
is some background going on. I think it might be from a phone caller, and I have a hearing issue, and I'm having a hard time hearing. So could you possibly mute everybody until we have questions? That's the first thing. And then I can't
New
remember.
message received.
Is the color of your eye, is that the iris or the pupil?
It is the iris. So the pupil is the dark hole in the middle, and then the iris is everything else. Or the iris is the actual color because that's where the muscles are and everything like that. So the iris, it's the amount of pigment in the actual. I'm doing 2 things at once. I really should just focus on what I'm doing here, because I'm trying to find the mute. Hold on. Let me do this first. Oh golly, now I just lost that whole screen.
You had a roll going. I'm sorry, Dr. J, but I
That's okay. That's okay. Now I've totally found. Oh, there it is. Okay,
No
there's
message
Lace.
received.
I guess maybe I'm getting too old, and it's a Monday night. Like I can't really remember all this stuff here. Where? No, I don't want to do that. Okay, found it. Okay, there we go. So I'm going to mute everybody just for that reason. Just give me a shout out and unmute yourselves. I did not take that possibility away. Okay, so going back, so the amount of pigment in the eye in the iris determines your eye color, and that is all genetic based. So if you have a blue eye, for example, a blue eye does not have a lot of color in or a lot of pigment in the iris, and therefore there's not going to be a lot of pigment in the retina. So therefore, when light enters the eye, those people with blue eyes tend to be a lot more light sensitive because that extra pigment actually absorbs light and prevents light scatter. So it's actually pretty cool because therefore we recommend those with lighter eyes definitely make sure you wear sunglasses. And those people also get more prone to macular degeneration. Again, because if there's lighter pigment in the eyes, generally there's lighter pigment in the skin and everything like that. And that extra pigment helps, there's a protection mechanism there. Now, the more pigment you have, the darker the eyes. So this would be your brown eyes. Now, having green eyes tends to be one of the most rare traits because it's kind of an in-between for how much pigment the eyes have. So again, it's all based upon pigment. That's what creates the color. So little tangent, not going to ask about it, but it's good information to have. So okay, so we are going to swing back to the refractive powers. So basically, the really cool thing, we know the cornea has a curvature and that bends the light to get back to our eyes. So you can take what's a topographical map, just like we can do a topographical map of the United States to see what the elevation is at different areas and maybe the bottom of the ocean. Well, we can do the same thing with our cornea. And therefore, we can do a pathological evaluation to see, like, for example, if somebody has keratoconus, like we talked about, we can see how that cone is actually protruding out of the cornea because there's going to be a spot of very irregular curvature in that area. So we can use a topographer to see for corneal laser surgery if the person has high astigmatism, surface of the cornea, and then fitting of contact lenses. So topography, you may get to see it, you may not. But again, I think it's pretty interesting. Now, I only bring this up because I want to talk about how finite the laser is that we use in refractive surgery. So an excimer laser is still what's used. It is what's used for refractive surgery. And this is the exact same laser that IBM used to make the microchip in 1981. I do have a picture that has a hair follicle that has IBM written on it twice. So let's think of a piece of hair that has the letters IBM written one above the other on a follicle of hair. That's how fine the laser is. So that's what I kind of want to use that example of just, to me, that's incredible. So obviously you got to use massive amounts of magnification to see that. But again, it's pretty cool. If you are wondering if you're myopic or nearsighted, there is going to be more central cornea that has to be removed. If it's hyperopia, again, it's more mid-peripheral tissue that's removed. And again, I'm not going to ask you about the type of treatments here, but if you're wondering, because if you're nearsighted or farsighted and we're wondering, okay, where does this tissue have to be removed? The whole point of refractive surgery is changing the shape of the cornea. And again, I also bring this up because problems can happen with LASIK surgery or some types of refractive surgery, and people can, it's very rare, but can have visual problems that pop them into the low vision category after it's done. So there's different kinds of different names here. I'm not going to really go through these. You can read these on their own because I'm really not going to test on these here. So now, without further ado, let's go to the retina and what diseases cause blur that pertain to the retina. So we're going to talk about the big one first. This is age-related macular degeneration. It can be called AMD, ARMD, the MACD, whatever you call it. MACD or macular degeneration it's one of the biggest causes of vision loss here. And this is the loss of central acuity and is actually the leading cause of reduced vision among the elderly. So between the ages of 50 to 59, only about 2% of the population is affected. But among reduced vision, so the reduced vision reasons at that age group, excuse me. And then after 75, this affects 30% of those that are visually impaired. And there are two causes, non-exudative and exudative. So we're going to discuss those here next. So there's different things. Basically, you get that loss of the foveal reflex. There's all of those photoreceptors that are right at the fovea. And so when I look at the back of the eye, there's actually a reflex because there's actually a little divot because they really just pack and cram all those cones in that area. And so there's a reflex when you shine light back there and you lose that because that contour is gone. There can be pigmentary modeling. So all of a sudden this pigment that we just talked about with the iris, that same type of pigment in the back of the eye, in the retinal pigment epithelium, the very bottom layer of the retina, starts changing and clumping together and grouping together. And then you can also get what's called this drusen. So there's these breaks in the retina itself that starts causing the retina not to be flat. So if you think about the film of a camera again, there's these defects in it that's not going to give the patient a clear image. Then you get that neovascularization, and this is blood vessels gone wild. They are partying like it's 90s style, and they are just growing wherever and causing fluid to leak out and vision to reduce, and they're just having a good old time. And the biggest thing with the retina, it doesn't like blood. Like if blood is in the blood vessels, it's great. It's doing its job. It's feeding the retina. But once retina or blood is just kind of hanging out there, the retina doesn't like it. And then it scars to try to stop it. And when the retina scars, that kills the photoreceptors and everything because it's the body's response to try to heal. And that's where massive amounts of vision loss happen. So different things that we can do in the clinic to watch it. You can give a patient an Amsler grid. This is a grid-like pattern of certain measured blocks and everything. So it's literally a grid. It's like grid paper. So tiny little squares put together that a patient watches so they can watch it at home and see, okay, are there any changes? We can take photos. We can do ultrasounds of the retina and this laser scanning just to kind of get a good detailed picture of what's going on at the cellular layer of the retina. You can also do fluorescein angiography where they do an injection of a fluorescein dye to watch what's going on with the blood flow to see where exactly the blood is moving in the eye to really give a good picture. So those are all different ways that can happen in the clinic to watch the progression of macular degeneration. Now to specifically look at non-exudative macular degeneration. Other names, this could be called dry macular degeneration, which is the most common in the lay terms. But what I find with patients, if you say that they have the dry form of macular degeneration, they're like, but my eyes tear. I must have the wet macular degeneration. It's like tears, front of the eye, this all in the retina, not related whatsoever. So 80% of patients suffering from macular degeneration, this only accounts for about 10% of vision loss. It is a very gradual case, and the vision loss is very much dependent on the macular changes. So whatever's going on, the pigmentary changes, the drusen, things like that, this is how the vision gets affected. So the more often that happens. Now, if they have the very much advanced dry form of the macular degeneration, if it's very, they've lost vision, there is a risk of it converting to the wet form or the exudative form within 5 years. So what do we do to treat it? There's observation, and there is also ocular vitamin supplementation. You've probably seen all the commercials about potentially AREDS 2 formulation. These are specific vitamins that really have shown to reduce the risk of further vision loss by giving the eyes the nutrients that they need, because God only knows that we're Americans. We eat generally what we want. Not everybody follows a perfect regimen of a diet. So therefore, this really gets the eyes exactly what they need at the right dosage. This has been a 30-year study basically now of, okay, what are the best nutrients? How do we reduce the risk of vision loss? And these vitamins have been shown to have it. They're working on stem cell regeneration. There is actually a new injection that you might see. But as I talked to the retinal specialist, for a treatment of it, the jury is still out on whether or not this actually makes a difference. So I feel like it's too soon to say whether or not yes, there's a treatment now out there for non-exudative, which is brand new. But again, as I've talked to other docs in the last 9 months, there's a lot of hesitation because there's been some patients that have really changed. Their vision is drastically worsened. So, Cindy, what is up with the reservoirs for MD? I'm not exactly sure what you're meaning by reservoirs in that statement. So get back to me and we'll dive into that a little further. So that risk for the conversion to the wet form of macular degeneration, again, this is just that large drusen and these large calcified deposits that show up in the macular area. You get this large area of atrophy. Again, I can use geographic atrophy because they literally talk about GA in those commercials. So if you've watched any type of television, you may have seen that. Again, pigment clumping, and if there's development of the neovascularization in one eye, it's very likely that it's going to happen in the other eye as well. So there's always a risk of it changing and going from there. So with exudative macular degeneration, this only accounts for about 10% of patients with macular degeneration, but does still account for 80 to 90% of the vision loss. So again, the majority of vision loss comes from a very small subset with macular degeneration. So the question is, so is drusen just a byproduct that the eye makes as it ages? Yes, long story short, we don't exactly know how it develops. Again, but it does look like it's some kind of immune modulated response that happens because we get older. So, and a CNVM is the choroidal neovascular membrane. That is, I just use it as abbreviation, but so yeah, if you see neovascularization, that C just means it comes from the choroid, which is right below the retina. So great question. Thank you for clarifying that. So with wet macular degeneration, this happens in days to weeks. It happens very fast. You get the growth of new blood vessels from the choroid. When we say that growth of new blood vessels from the choroid, that is exactly that CNVM that just was asked. Gosh, that was perfect timing. That is the choroidal neovascular membrane. And again, you can get hemorrhages, you can get scarring. Again, I have on here specifically fibrovascular scarring because it's scarring that happens from, or this fibrous vascular, the scarring from the vascular tissues. Whew, that was really hard for me to say. And then exudation is just leakage of blood vessels. So that's all the different things that happen at the back of the eye. So really the macular area is having a war in it is the best way to put it. I don't know why I'm all about the war. You'd think I'd worked at the VA or something. So different ways we monitor this is, again, fluorescein angiography. There used to be, it was the gold standard to use a laser and kind of shoot those new blood vessels. And when you kill those new blood vessels, you're also killing good parts of the retina. So now you got a huge blind spot in the eyes. So what is the treatment that's happening now? It's not lasers. It's very rare. In fact, if you have a retinal specialist that your clients are going to in some parts of the area, and what do I want to call it? That your doctor is using lasers, oh my gosh, run, 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 run. So we have these new injections. These are literally, yes, please talk to the patient to get a second opinion. So yes, but you need to see a retinal specialist. And honestly, any good eye doctor is going to be getting these proper referrals made. But they literally put an injection into the vitreous. So this is a needle going into the eye, into the vitreous, and doing an injection every 4 to 12 weeks for treatment. It stops the proliferation of new blood vessels. So again, you don't get to that point where the retina is scarring. So that, in a nutshell, is, let's see here. Just want to make sure I got this. So a treatment for macular degeneration wouldn't also treat Stargardt's, correct. So we're going to get into Stargardt's here next. Macular degeneration is a different pathophysiology than what's happening in Stargardt's, the next one we're going to talk about. So yes, it does not happen the same way. So therefore, the same treatment cannot be used. Trust me, they've tried it. One of the injections that they found for, which actually was quite a different one, was a treatment for colon cancer. So they were looking at what they were doing with the eye that was actually helping, and then they looked at a drug for colon cancer that was ironically much cheaper, and the molecular structure was very similar, and they found out they saved a ton of money and it worked just as well, which was kind of cool. So it's just amazing as you really get into chemistry and look at what can happen. So something that might help for colon cancer can also help with the eyes. So with Stargardt's disease, the onset is 6 to 20. So we just talked about macular degeneration as a 55 and up disease. Stargardt's, on the other hand, is onset 6 to 20. Obviously, it never goes away. So you get this lipofuscin versus the drusen. So lipofuscin is a yellow, rich waste, where drusen is more of a calcified deposit. That's the difference. And this accumulates within the retinal pigment epithelium, so the basement layer of the actual retina. So it starts by breaking down the rods just outside the macular region and slowly moves inwards towards the fovea, where it spreads to the macular cones that causes a loss of central vision. So therefore, obviously, you get a blind spot in the center. So again, the results for the patient are very, very similar, but generally, once Stargardt's, it doesn't really progress. Like by the time you're 20, it's really done. The damage has been done, and it's not truly a progressive disease at that point. So this is one of those things in medicine that there's a bunch of different terminologies. So you can call it Stargardt's macular dystrophy, juvenile onset macular degeneration, or my favorite, fundus flava maculatus. Just because it's fun to say and you can impress your friends with Jeopardy, But generally, if I see Stargardt's, that's what I'm going to be looking for. I'm not going to be like, what are the other names for this? I just want you to know Stargardt's, because I rarely, unless it's like the VA, there is a technical differentiation if you want to. But if you are with a doc that's a big researcher and things like that, yeah, you might want to be familiar with fundus flava maculatus. But you won't forget it now because I've said it a few times and it's fun. Next up, we have adult vitelliform dystrophy. This is called Best disease. Now, it's called Best disease not because it's the best disease to have. By golly, it's the worst, or it's the second. You don't want Best disease, but why medical professionals want to name themselves after something that's a disease that causes a vision impairment is beyond me. I don't get it. But people and their egos. But anyway, this is a young onset macular degeneration, is very similar to dry macular degeneration, just a slightly different pathophysiology. The big thing with adult vitelliform is that it happens between their 30s and 40s. So macular degeneration, 55 and up, adult vitelliform is going to happen in their late 30s to 40s. So next up, right at the macula, we have what I call an epiretinal membrane or a pseudohole or a macular pucker. Basically, what this is literally the top layer of the macula all of a sudden wrinkling. So it distorts your vision. The photoreceptors are essentially fine, except because you're getting a wrinkling, the photoreceptors just kind of get distorted back there and causes distorted vision. So you get this pulling of the vitreous at the macula that distorts or reduces vision. And it just depends on how much distortion, on how much vision impairment happens. Yes, there is some actual treatment that happens with this if it gets too bad, but because you're trying to pull off that wrinkling area, obviously there's going to be some disruption of the retina, so that can be you have to have a certain type of level of vision impairment before they actually go through and do it. Now, with a macular hole, this is kind of the end stage of if the vitreous, or, we talked about all these placements of the vitreous, attached to the back of the eye. Well, the macula is one of those areas. And we also know that the vitreous is, if it's attached to the macula, as it liquefies that we've talked about, it can actually pull at the macular area and actually rip the whole retina from the macula. Well, all of a sudden, if you don't have any photoreceptors in the macular area, all of a sudden that area becomes just like the optic nerve. So therefore, if no photoreceptors are there, there's no vision. And so there's different stages of that, but if it completely happens, it produces an absolute central scotoma or an absolute blind spot. There is no vision there. Again, just like the physiological blind spot, which is at the optic nerve. Again, the optic nerve has no photoreceptors. So just to make sure we're all clear on that. So that's kind of the macular area. Those are the big ones, at least, that are going to be affecting the macular area. So next up, we're going to talk about diabetes. So we're switching gears a little bit, talking about diabetes. So this is the inability of the body to control the glucose levels. And generally, diabetes, especially type 2, it's extremely prevalent. And we know that 2/3 of Michigan's population has a BMI over 25, and 32.3% of Michiganders are obese, and this is a BMI of over 30. Now, you can say what you want of the BMI scale. It is a very old scale, so take it or leave it. It's a scale that I don't think takes into account reality, but it's the best we have right now that they've agreed upon. I have no idea what the 19 or 51 stands for. So maybe that's a locker combination. I have no idea. But so ignore what the 19 or 51 stands for. But again, Michigan's adult diabetes rate as a few years ago that I could find was 11%. And there can be numerous ocular complications. Not only is there, a lot can happen with the eyes, but you can have peripheral nerve disease in the hands, the feet, any extremities. There can be kidney disease and any vascular problems. So diabetes itself is a disease of the small blood vessels because basically I'm getting a question to pronounce duodenum. Hopefully that helps. So it's the oddest spelling, but duodenum is Duodenum. Okay. Let's see here. So diabetes, small blood vessels, disease of small blood vessels, the extra blood sugar within those blood vessels causes them to become leaky and causes damage. So type 1 is it's insulin dependent. So you need insulin because the pancreas itself is not creating insulin. That's where it comes from. Insulin controls the body's blood sugar. And this is either genetic or it could be immune, and it's early onset. So you generally are diagnosed with type 1 very, very early on in life. Type 2 is non-insulin dependent. There is a decreased pancreas function, but you still got some insulin that's naturally made. So it's generally related to obesity. It's just your body's requiring more insulin to control that blood sugar because there's a lot of obesity happening. There's a lot more your body just needs a lot more insulin because there's more body mass to help get the extra blood sugar out of. Now, the interesting part is there's a lot of weight loss medications that have been remarkable in helping people control their diabetes. And so it's just going to be interesting over the next few years what is going to happen to the weight population, especially if they can get the price of those weight loss medications down, which are absolutely used in diabetes. This is your Wegovy, your Ozempic. Things you're seeing. Just happened to watch a thing on nightly news or something because I'm old and that's what I watch. And basically, I can't even tell you how much more it is here in the United States than it is overseas. And so it's ridiculous. So it's really going to be interesting what's going to happen now that the pharmaceutical companies have been what do you call it? So the blah the I need to stop paying attention to the chat when I'm on my tangents here. But basically what happens is it's just going to really help control the weight population because I think that's going to overall bring down medical costs if they can get those drugs cheaper. Whew. That's what I was going to say. So lost my vision when in preeclampsia. I've been type 1 ever since the age of 2. My retina's hemorrhaged. No doctor has been able to explain this. So I am not 100% sure. It's just with all of the, there's a lot going on with preeclampsia that can, there's a lot of side effects, obviously. And so, the retina's hemorrhaged, but my guess is it's not due to diabetes. But again, that's just literally my guess. So that's a good one. I think I saw Gwen. Did I see Gwen having her hand raised?
Yeah,
Go ahead if you got a second. Were you able to unmute yourself, Gwen? Let's see.
can you?
Yes.
I'm trying to.
Are you still with us at all?
Can you hear me, Doctor?
Yes. Yep. Go ahead.
Are, are, are you able to hear me?
Yes. Yep. We can hear you.
Okay. I just want to mention it's very concerning. I heard of a very recent study that was up to 7 months. Are you familiar with that?
It's really breaking up. It's really hard to hear you, Gwen.
Oh, well, can you hear me now?
Yes.
So the Ozempic has been linked to sudden blind, a rare condition which can cause sudden blindness.
Oh, really? Okay. I have not.
Neuropathy or condition that can cause blindness. So yeah, this is a pretty recent study. So just want to let people know about
So
that.
if you don't mind, just because that was kind of breaking up a lot when you were taking it, but definitely please place that in the discussions because that is just absolutely it's great. Um, Just because it was breaking up, so I apologize about
Oh,
that
no.
here. Sometimes the internet connections I know have been wonky here. So and there's a advice sometimes if you want to talk, maybe turn off your video. Sometimes that can help the sound come back through and everything like that. So but yeah, definitely thank you. But yeah, I will have to look up more about the potential side effects, obviously, that can happen with you know, these medications, because nothing is all good things must have something wrong, right?
I
Alrighty.
think I heard there may be class action lawsuits going on right now. I'm not positive, but
Oh, if it
maybe
was
it's
really
in the
causing, if it's causing blindness, of course, there's going to be class action. I mean, this is a very sue happy country, which I mean, I get it. I mean, I would not be happy with that either. So
right.
really quick, just going on to diabetic retinopathy here. So in the early stages of diabetic retinopathy, this is literally bleeding in the retina, or where we start getting to the more advanced stages of diabetes. And so there's these small microaneurysms, or the small leakage of blood vessels within the retina. And the vessel leakage, because again, the excess blood sugar causes blood and fluid to leak. This is why we so harp on keeping the blood sugar levels, you know, at a healthy level, because the higher it gets, the worse it's actually going to be. So when it starts becoming more and more serious, again, we're watching very closely, but if you have diabetic macular edema, this means you actually get swelling in the actual macular area from the diabetes, from that excess fluid, and that starts causing vision loss. And you may hear diabetics say, I have Swiss cheese vision. Well, if you think about Swiss cheese, you know, there's little holes in it. So all of a sudden their vision, they've got spots of good vision, they've got spots of blacked out vision. And that's because of the blood and fluid there. Now, we also can get to the proliferative type of diabetic retinopathy, which is the severe stage where there absolutely must have treatment. Same with macular edema. We need to treat it. But you can get this whenever you see the word proliferative, that means there's some type of neovascularization or some type of new blood vessels that's going on. So this can happen within the iris, it can happen within the optic nerve or the optic disc, or the retina. So those three areas, because the new blood vessels have a they're very leaky. They break very easily. They can actually lead to a retinal detachment, which actually causes the retina to detach from the back of the eye. And those blood vessels can simply clog the angle of the trabecular meshwork. So therefore, no aqueous can get out, and aqueous is still being formed. So that causes eye pressure to just zoom right upwards. Not to mention that the blood vessels are leaky, they can literally cause a break and let blood just flow into the vitreous, and it, you know, therefore now you can't see. So it causes blur or potentially blacked out vision, just depending on how much blood is in the back of the eye before the body can naturally stop it. I've heard that Hispanics and African Americans have higher rates of visual threatening diabetic retinopathy. Is that due to access to care or something else? Generally, it is sadly thought to access to care. So different, unfortunately, socioeconomic statuses, you know, racial disparities within healthcare. I know this is why, for example, here in Michigan, I have to actually do oh my gosh, and I've taught the course, but it's all about implicit bias training, just because, again, to try to make sure we're aware of what's going on, how we're practicing, and making sure we're doing the best job. But yes, I do think it's due to access to care, and, you know, being aware, education, all of that stuff of why it's so important to have, you know, get treated for things that you actually have going on with your body. So great point, Cindy. So diabetic treatment, this is the leading cause of severe irreversible vision loss. We know cataracts in the world are most sight threatening, but that's reversible because we have the ability to do this. But in diabetic retinopathy, once the vision is lost, if it's beyond the point of no return, there's no saving it. So the biggest thing is, weight management through diet, exercise, controlling that blood sugar. So these are things you can do as a person if you have diabetes. And then obviously we have medical management, glycemic lowering medications, insulin, bariatric surgeries out there. And then now I didn't even put it on here, but the new weight loss drugs that are out there. Now, other different types of retinopathies that you may see, there is what's called hypertensive retinopathy that is caused from uncontrolled blood pressure. We know that 34% of Michiganders have high blood pressure. And so there are vascular changes when the blood pressure is too high, and you can get what we call hypertensive retinopathy. This is where you get some type of swelling at the macula or within the retina, excuse me, that causes the vision to decrease. And those, because of how the blood vessels are, they can actually block other blood vessels. You can also have HIV or AIDS retinopathy, which is a weakened immune system, and therefore it leaves the retina open to attack by other viruses. So there's other retinopathies out there besides diabetic retinopathy. So just don't think if you see the word retinopathy, it may be another kind. So make sure you're looking to see what exactly it is. Now, just to go a little bit more over ocular anatomy here, we have what's called the central retinal artery. The central retinal artery enters the eye through the central part of the optic nerve. So it literally slides up the middle of it to feed the outer 9 layers of the retina. We know that the bottom part of the retina, the RPE or the retinal pigment epithelium, is fed by the choriocapillaris of the choroid. So that comes from there. All the other levels, the photoreceptors, on up to basically until the retina hits the vitreous, that is all fed from the central retinal artery, and that's where it gets the blood, nutrients, oxygen from. Now, so in retinitis pigmentosa, we'll talk about, I don't want to get into retinitis pigmentosa. It's not affected by the artery or anything like that, but we'll talk about that, Lauren, when we get to that part, because that'll be in field loss in a couple of weeks here. So a central retinal artery occlusion literally means when that central retinal artery is blocked, so there's no blood flow coming to the back of the eye. This is called a CRAO for the abbreviation. It is ocularly devastating, where there's some type of blockage blocking the central retinal artery that basically causes the 9 layers of the retina to undergo necrosis. They die. This is literally a stroke to the eye. It is a sudden and total loss of vision that's permanent. Once it happens, basically you got 20 minutes to get that embolus out so the blood can start flowing, or that vision loss is permanent. Just like we have the central retinal artery, that central retinal vein takes the blood out through the same way. So the Jennifer, we're waiting on the retinitis pigmentosa to talk about it during the field loss there, so no worries about that. So the central retinal artery, or the central retinal vein, is just like the central retinal artery. This basically sends the retina, it drains from the retina through the optic nerve, so it gets all the blood out that the central retinal artery has taken into the eye. So with a central retinal vein occlusion, basically you get blood that backs up into the retina. So different diseases that make you more prone to this happening are diabetes, high blood pressure, polycythemia, and glaucoma. So different things that are causing, blockage to the blood flow, that's what makes you more at risk. So if you're hearing anything from me tonight, it's take good care of your body, because a lot of this can be at risk. So, the thing with this is you don't know if your blood is stopping or, getting backed up until it's too late. So this is why those annual exams, I had a 37-year-old. The guy looked totally healthy, came into the office with a central retinal vein occlusion. Had we not gotten him in for treatment, he would have lost his vision and bad things could have happened. So there's going to be a lot of hemorrhages. The retinal veins appear tortuous. Tortuous, the best way to call it, is they look snake-like. The blood vessels generally are smooth flowing through the back of the eye, but all of a sudden there's all these kinks and chains and things like that that are moving through there. And so that's what's causing the blood to kind of back up. And then you get swelling when you see the word macular edema. That is literally the swelling at the macular region, and that can cause permanent macular degeneration, a different type of macular degeneration that's not age related. So different things that happen there. So that's a lot that can go on here. So the other things with retinal vein occlusions, how they can get so bad is you can get retinal ischemia. When you see retinal ischemia, that means there's no blood flow flowing back there. So if there's no blood flow, the eye is trying to figure out how can we get blood to this area that's not getting it. So therefore, all these new blood vessels grow, and so you can get neovascular glaucoma, which you get all these new blood vessels that crowd out the trabecular meshwork and can cause severe pain. And ultimately, because there's no treatment for it, they have to actually remove the eye, which is what enucleation means. So it can get very serious very fast. We don't take this as a joke. Now you can also get a branch vein occlusion. You get fewer visual complication unless that macula is involved. So again, it just depends on where it's at, where the swelling's at, where the vision loss is going to happen. Whew, have we had enough yet? Unfortunately, not so much. So next up, we have central serous chorioretinopathy. This is also abbreviated as CSCR. This is a mild retinal detachment within the macula. So the retina actually detaches from the back of the eye. And this is most common in males with a type A personality. Thank God I have never had one of these, but I do have my laid back approach sometimes where I don't get dealt with too much stress. So thank God. But ages 25 to 50 and stress, you do tend to see this. If you're at the VA, you do tend to see this because again, these are males, type A personality, 25 to 50, stressful situations. That it's definitely a thing. I know as we get more women in the workforce, the thought is, okay, can women have this more? And there is thought to be a relation with this and testosterone. So women are kind of saved where you really don't see this too often in women, but it is a possibility. So what does it do? If you have a small retinal detachment, you're going to get blur or distorted vision. And with this retinal detachment, it can resolve on its own. So you might get your full vision back without a problem. But as it's happening, you get blurred or distorted vision, you get loss of color perception, and if this repeats, then you get more and more problems. Whew. So next up, we have histoplasmosis. This is an infection from the fungus Histoplasma capsulatum, and it is very endemic to most common to the Ohio and Mississippi river valleys. And just to make sure you're awake, I call this the chicken shit disease, basically because this is exposure to chicken feces. Now, it's not like we go play with chicken poop or anything like that, but I mean, what do chickens do? They poop. And when you're a kid, what do? You play in the sand. Now, generally, you're not playing where the chickens are, but if you have chickens, and more people are having chickens these days, Cindy, case in point, you got 22. Got to watch out for, histoplasmosis. And I kind of laugh about it, but it is a very true thing that if the fungus is, if you're exposed to fungus, one of the places the fungus goes is to the eyes. And it can happen at any age. So basically what happens, it makes these punched out retinal lesions where it literally looks like somebody took a small round cookie cutter to the retina and just removed it. And that's obviously a really bad thing if it happens at the macula, because all of a sudden, boom, the macula is gone. All of those photoreceptors that are giving you the fine detailed vision is very bad. And so Jennifer, you put on here a very good advertisement for a vegan diet. However, just it's not from eating chicken. So it's literally, it's not from eating chicken, it's from their poo. And so if you're exposed at all to their poo, that's how you get. So unless, again, so vegans can get this too. They're not stayed away just because, again, dust flies, is what I'm trying to say. And so if that poop, if that fundus, oh my gosh, if the poo gets into the sand and the dust starts flying, well, if that fungus is in there, you can, breathe it in, boom, there you go. So anyway, you can get this parapapillary scarring that literally means scarring around the optic nerve. And you can get, again, our favorite term, that subretinal neovascular membranes. The blood vessels can go wild. So there we go. Let's see here. Next up, we have toxoplasmosis. This is from the protozoan Toxoplasma gondii. This causes a chorioretinitis, or an inflammation between both the choroid, which we know is the bottom layer of the retina, so just underneath the retina, and the retina itself. So it's an inflammation there. And that most common area happens is the macula. Now with toxoplasmosis, it's not like we can just go in and be like, okay, let's do a biopsy to see what's going on, because you get these inflammatory deposits in the brain as well as the retina. You can't just take those out just to see what's there. So basically we do just a clinical diagnosis literally by how it looks. It happens in both eyes. And thankfully we can treat this with antibiotics. And it's very aggressive when it's close to the macular or optic nerve. And again, the big thing with this, it can be caught, though this comes from kittens. So yes, more poo is, again, this is a really shitty lecture. I'm so sorry, everyone. But again, this is, one of those things that we have to deal with. Again, you don't see a lot of toxoplasmosis, which is a good thing here in the United States. But again, it is definitely one of those things that we have to deal with. Now, we also have dystrophies of the retina that can happen. You can get a cone rod dystrophy. These are pigmentary dystrophies that primarily happen in the retina, in the macular region. So basically, you have a destruction of the cones. Anytime we see a destruction of the cones, we get a decreased visual acuity, or because it's in the lecture, we get blur. And you also get reduced color vision because, again, color vision comes from cones. The other thing that, the other type of dystrophy we have a rod monochromat. This is literally where you are born from a genetic malformation where you only have rods in a person's vision. So there's only rods instead of cones in the macula. We know that rods literally only see black and white and everything in between. Hence my 50 Shades of Gray statements and everything like that here. But basically, a rod's ability to see the visual acuity is about 2200. So that's literally the maximum vision a patient that's a rod monochromat can have. And again, we do consider this a retinal dystrophy. Again, there's no colors or anything like that in the person's vision, and the vision is reduced. Now, the good thing about the rod monochromat, it is what it is. There's no progression of this. The cone rod dystrophy, absolutely there is. So because that can get out of the photoreceptor region there. Now, eclipse burns. We had the big Great American North eclipse, which we talked about a little bit last week. Your mother was right. Never stay at the sun. The macular area is literally burned by infrared rays because you can actually stare at the sun for a while. You don't want to do sun gazing. It is not good. No, 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 because the lens and the cornea act like a giant magnifying glass. And it's not a good thing. And again, this is very similar to laser pointer burns. Those are becoming more common again lately. So you don't want to, point a laser pointer at somebody's face, because that is not a good thing. Because again, the eyes do tend to be sure that they're you don't want to burn somebody's macula out, and that's really scary. So um I had no idea. Okay, Lisa, you totally made my night, because I did not know about um that dogs could have herpes. So it is much safer to kiss a dog than a human. Okay, that's what I'm taking out of Lisa's message. So perfect. Okay. Here we go. So that is all. Like literally from what we talked about for the last 4 weeks, that's what's going to be on the midterm. So just things to keep on your docket. The module discussion is due October 6th. The Blur Part 2 quiz is due October 6th. That darn midterm opens on this Saturday. And there will be no lecture next Monday, just to let you guys know. I am doing a special study session this Friday. It will be at 8 o'clock. So, hold on to your panties, because this will be a good time like we had last time. So it's your time to come and ask questions and everything like that. So the breakdown, basically there is 36 questions on part 1 and 36 questions on part 2. You will have 60 minutes to discuss that. And to go from there. So yes, Cami, we can talk about after class. I'll make sure we try to get that private here, unless you don't care. So there will be 15 true false, 10 multiple choice, 5 fill in the blank, 3 short answers, 1 essay, and a partridge in a pear tree. So part 1 is 125 points. Part 2 is 115. So that's kind of what we have going on there. If you have not submitted your project submissions, you just have a good less than 3 hours. That time clock is on to get your research project source submission submitted. And then 2 weeks from tonight, your outline is due, which I don't have in here, but October 14th. Haley, you have 60 minutes to take each part. You do not have to take each part in the same day. So hopefully that helps. But with the research project outline, I don't want you to overthink this outline. It is literally how you are thinking you are going to want your research project laid out. So what are you actually doing? Okay, this is what I'm going to talk about. This is going to be the order. However that makes sense to you, I just want to see that you've got a game plan. And so that's literally all I'm looking at for you as you're doing it. It can be as short or as long. I want this to be useful for you, is to create your outline here. So hopefully that helps. Now, to help you out, I had all the quick exams graded. Oh, really quick, Cindy asked, it says summary, do you want an abstract? No, we do not need an abstract. It is literally, I just want to see your roadmap. So just an outline is fine. Last night I had I had an e-learning glitch. And so therefore not everybody's exams released last night. So I did just get those released. If you're wondering what your grade was, I'm actually really impressed. You guys did very, very well. The average was right where I was hoping it would be, actually a little bit higher than I was expecting. So kudos to you guys. You guys are doing great so far. And like I say, I have no doubt that you guys will do well on the midterm itself. If you have any questions about the midterm, definitely please, or even exam questions, we're going to wait until this Friday. If you can't make this Friday's study session, it will be recorded. So please know that I will definitely be doing that here and everything to that nature. So hopefully that helps out with that.
Okay.
Did I hear somebody?
Yeah, it was me, Christy. Can I ask?
Oh, yeah.
So two things. I thought the references were not for our paper were not due until October the 3rd.
No message received. Leave session or end meeting. Button.
Because that's what it says on
No message received.
Let me see. No, I have in the module here today, or in the syllabus, it says today.
Oh, okay. And then my other thing is I don't understand what you're talking about, the module project or that's due on the 6th. I don't understand. Maybe I missed it. I don't know what you're talking about.
Oh, so it's in e-learning, it's just breaking down into modules. So just remember the discussions and the quiz is due on the 6th.
Session.
So
Yeah.
everything over Blur, so in e-learning, this Blur section, section 1 had a quiz and section 2 has a quiz. And then there's just one discussion section for that module.
Where we post, do you post a question or do we ask questions? I'm not sure.
So yeah, so the instructions are right within the discussion section. So just go to the discussion section. That'll explain exactly what to do.
Okay, well, I'm gonna be sending you an email because I got issues.
No problem.
Thank you.
Yeah, no problem.
Leave session or end more. Select audio AI assistant. Start video. Music. Button.
Sarah asked, can you do the breakdown? I will actually go ahead and just be very nice. Gosh, when I said Sarah, that my Siri activated, that's funny. So what I'm going to do is go ahead and I will put that in the news section to give that breakdown one more time, because again, I didn't expect you to do that. It'll obviously be in the transcript when that transcript of this whole recording gets placed here today. And so, yeah, you'll be able to see it there as well. And somebody, Eric just put Go Lions. If you got a score update, I'd love to see it because, I don't know. I don't even know what time the game started tonight, but I do know the Lions are playing, so we got to get to them. 21-7. Absolutely. Thank you, Eric. I appreciate that here. So, and I am so glad I'm not the first one. Eric, I don't blame you. You guys clearly see how distracted I'm, like a squirrel. I see something on the chat. Can you imagine if I was watching the Lions right now? I mean, I've enjoyed the Tigers, the Lions. I mean, it's been a great year to be, Michiganders here. So, but I totally appreciate that you at least have it on. That is a true fan right there. Okay. Is there anything else here? I know Cammy's got something for me. I'm going to go ahead and turn off the recording, and so I can let this start downloading and doing this thing so I can get this posted.